Welcome to the weekly Neurology Deep Dive. We're produced by Amer Gavanini. Today, we're focusing on a really insightful paper from Latvia that gets right to the heart of a tough clinical problem for all of us: refractory myasthenia gravis.
And we're going to be doing a thorough analysis of their prospective cohort study, which looks at using rituximab in these very challenging patients.
Before we dive in, though, we should get the usual disclaimer out of the way.
Yes, absolutely. This deep dive is for educational purposes only. It has no commercial goal, and this is a summary. We really recommend that you read the full paper to get all the details on methodology and context.
Our mission today is to explore the evidence that's adding to this growing body of knowledge that supports rituximab as a viable treatment for refractory myasthenia gravis. But it's more than just that.
It is. This paper offers some critical insights into which patients might benefit the most, and maybe just as importantly, when we should think about intervening.
So for the busy clinician who might be listening, let's start with the immediate actionable summary. What's the bottom line?
The bottom line is this: a single low dose of rituximab, we're talking 500 milligrams for most, 1,000 for one patient with a higher body mass index, was shown to be both effective and safe over 6 months in this small cohort.
And what were the critical metrics they looked at?
Well, clinically, the median Myasthenia Gravis Composite Score improved significantly. It dropped from 11.5 at baseline down to 7.5 at 6 months.
But the really big news, I think, is the steroid-sparing effect.
That's the key takeaway for practice. The median daily corticosteroid dose was cut down significantly, falling from 15 milligrams to just 8.5 milligrams.
And the benefit was seen across the board.
It was, but it was most dramatic in the muscle-specific kinase-positive patients. That said, the acetylcholine receptor-positive patients also showed overall clinical improvement and, importantly, didn't require any rescue therapy during the entire follow-up.
Okay, so let's unpack this. The core dilemma here is that while standard therapy works for most myasthenia gravis patients, you have this subset, maybe about 15%, who remain refractory.
Exactly. These are the patients cycling through high-dose steroids, azathioprine, mycophenolate mofil, and they're still struggling, often with recurrent myasthenic crises.
And the morbidity in that group is often driven by the treatment itself, right? The side effects of prolonged high-dose corticosteroids.
Precisely. You see bone fragility, infections, steroid-induced diabetes. So the urgent need is for effective steroid-sparing alternatives.
This study, while small, was prospective. They screened 98 myasthenia gravis patients and found 9 cases meeting their very stringent criteria for refractory disease.
That's about 9% of their cohort, which really underscores how select this group is. And the median duration of disease was long 7 years. These were established treatment-resistant cases.
For our audience, let's detail those criteria for refractory myasthenia gravis, because this classification is key. Patients had to meet at least 1 of 4.
Right. The first was severe instability, so recurrent admissions for myasthenic crisis requiring rescue treatment like IV-IG or plasma exchange.
The second was about steroid dependence.
Exactly. Requiring high doses, defined as more than 20 milligrams daily, and being unable to lower that dose without symptoms getting worse.
The third criterion focused on toxicity, severe side effects from the corticosteroids or immunosuppressants that were getting in the way of properly managing the myasthenia gravis.
And the fourth was just persistent disease activity, despite what should have been adequate therapy. So a myasthenia gravis composite score of 10 or more, or a daily living score of 6 or more, even though they'd already failed steroids plus at least one other agent.
And the patient breakdown was, what, 7 acetylcholine receptor positive and 2 muscle-specific kinase positive.
That's right. And it's important to remember all 9 had failed previous standard treatments. They were truly at the end of the line, therapeutically speaking.
So this is where the intervention comes in. They chose a single low intravenous dose of rituximab. Can you detail that dosing strategy?
It was quite a specific approach. 8 of the 9 patients got a single 500 milligram dose. Just one patient who had a body mass index over 35 received a 1,000 milligram dose.
And they used a standard pre-medication to manage infusion reactions.
Yes, a standard protocol. Intravenous methylprednisolone, chloropyramine hydrochloride, and paracetamol to ensure a smooth infusion.
Okay, let's get to the results at 6 months. The Myasthenia Gravis Composite Score. A change of 3 points is considered clinically meaningful.
And they saw the median score drop from 11.5 to 7.5. That's a 4-point change. So it was statistically significant and clinically meaningful for the group as a whole.
But the really interesting story is when you break it down by serotype.
That's where the results become very stark. For the muscle-specific kinase-positive patients, the response was Well, it was profound.
What were the numbers?
Their median score plummeted from 18.5 at baseline all the way down to 2 at 6 months. That is essentially near complete symptom resolution, a massive change.
And in contrast, the acetylcholine receptor positive patients.
A much more modest reduction. Their median dropped from 10.6 to 7.1, and importantly, that change was not statistically significant.
So there's a lot of variability in that acetylcholine receptor positive group.
A great deal. The paper notes that only 2 of the 7 showed sustained benefit, and 1 actually had a mild deterioration. It makes a clear case for rituximab in the muscle-specific kinase positive subgroup, but it demands a more nuanced look at the acetylcholine receptor data.
Which brings us to the steroid-sparing outcome. This is often the primary goal. Did the low-dose regimen deliver on that?
It absolutely did, and this is probably the most practical takeaway. The median daily corticosteroid dose decreased significantly, from 15 milligrams at baseline to 8.5 milligrams at 6 months.
So about 2/3 of the patients were able to taper their dose.
About 67%, yes. And remarkably, one of the acetylcholine receptor positive patients from that more resistant group was able to stop steroids completely.
And that was with other immunosuppressants held steady.
That's a key point. Concomitant agents like azathioprine were maintained at baseline doses, which means we can attribute that steroid reduction directly to the rituximab.
Now, what about the patient's perspective? The quality of life and daily function scores?
They did show improvement, but without reaching statistical significance. The myasthenia gravis activities of daily living score decreased from 6 to 3, and the quality of life score improved from 30 to 23.
So they are objectively doing better, but it's not yet enough to move the needle on those broader quality of life metrics.
Precisely. Long-term quality of life is complex. It's influenced by the psychological burden, comorbidities, and, the cumulative damage from years of steroid use. That might not track perfectly with a 6-month improvement in muscle strength.
Let's talk safety. This is a fragile, heavily pre-treated group. What did the paper report over those 6 months?
The safety profile was excellent. There were 0 myasthenia gravis exacerbations that needed rescue treatment, no severe side effects, no cytopenia, no opportunistic infections.
So no grade 2 or higher adverse events.
None reported. And immunoglobulin G and M levels remained stable. No sustained hypogammaglobulinemia, which is always a key concern with B-cell depletion.
So what does this all mean mechanistically? Why the huge difference in response between the two groups?
It all comes down to the immunology, and specifically to rituximab's target, the CD20 marker on B cells. Muscle-specific kinase autoantibodies are predominantly immunoglobulin G4.
And their production is highly dependent on those B cells.
Exactly. So when rituximab depletes the B cells, you quickly shut down the production line for the autoantibodies, leading to that dramatic, rapid response. The disease is simply more accessible to the drug.
Whereas for the acetylcholine receptor positive patients, it's a different story.
A very different story. Their autoantibodies, immunoglobulin G1 and G3, often come from very long-lived plasma cells. These are like antibody factories that hide out in niches like the bone marrow.
And crucially, they don't have the CD20 target.
That's the key. These long-lived plasma cells lack the CD20 marker, so they're not directly affected by rituximab. You can take out the new B cells, but the established factories keep churning out antibodies. That explains the more variable and less profound effect.
The paper did offer one more practical point about that acetylcholine receptor positive group, though. Something about timing.
Yes, and this is an important observation. They noted that among those patients, the ones with a shorter disease duration, less than 5 years, had greater clinical improvement and more success with steroid tapering.
That's a critical finding, even if it's from a small sample. It suggests that if you intervene earlier.
The hypothesis is that if you use rituximab earlier in the course for acetylcholine receptor positive patients, before those long-lived CD20 negative plasma cells become really entrenched, you might get a better, more sustained response. Treatment timing could be just as important as the drug itself.
So to bring this all back around, let's repeat that practical summary for retention.
Final recap. A single low dose of rituximab showed clear clinical and steroid-sparing benefits over 6 months. The benefit was substantial in the highly responsive muscle-specific kinase positive subgroup, achieving near remission.
And for the acetylcholine receptor group.
While their individual responses were variable, as a group they showed overall clinical improvement, and crucially, none of them required rescue treatment during the follow-up period.
So the final thought for our listeners, the real challenge for us as neurologists is this. Considering the clear difference between serotypes and this hint that earlier treatment might help acetylcholine receptor positive patients. When do we pull the trigger on an off-label therapy like this?
It's a real clinical tightrope walk. Do you try it before traditional second-line therapies have truly failed to try and capitalize on that potential window of opportunity?
This single-center experience from Latvia gives us some valuable, real-world data to factor into that complex decision. We encourage you to read the full paper. Thank you for joining this weekly Neurology Deep Dive.